So I'm really thrilled, and I want to give you guys just a really quick introduction about our panel tonight because I said if I read everyone's full bios, we would be spending half the event reading their bios. These ladies are amazing. So first, you're going to hear from we have Tatiana Smith, who is a licensed professional counselor, supervisor, and also a certified Christian doula who is deeply committed to helping women of color through pregnancy and childbirth. We have Dr. Nicole Plenty, who is a double board certified OBGYN and maternal fetal medicine specialist. I'm going to share her vlog podcast called Pregnancy Pearls, and I'll get you the link to that in a second. Then we have Erin Carmen, who is an award-winning journalist who's currently a senior correspondent at New York Magazine. She's the author of the 2025 book Unbearable: Five Women and the Perils of Pregnancy in America. She has previously worked for CNN, MSNBC, Salon, and Jezebel. And then we also have Shakana Haley, who is a holistic intuitive practitioner, perinatal consultant, certified holistic doula, independent sociological researcher, and founder of the Inner Light Holistic Doula and Perinatal Counseling Center. Plus, she is currently on the faculty at Spelman College. So, like I said, I could read everyone's bios, but we would be here all night. So I'm going to bring up Julie Collins, who you guys all know, and she is going to be our moderator for this amazing panel tonight.
Good evening, everyone. So we're just going to go ahead and jump into this and get started. To start, I'm going to ask each of you to weigh in here. For those who are newer to this issue, can you all briefly explain how severe the Black maternal mortality crisis is in the U.S. and how it compares to other developed nations? Um, and kind of, if you want to start, go ahead and start.
Okay. Developed nations. In Georgia here, we are at F in the March of Dimes study on maternal mortality, maternal health and wellness. All right, Nicole. So we are at the bottom in terms of maternal mortality rates in general with other developed countries and just in context state to state. Um, the failures that we have in terms of Medicaid expansion, in terms of access, hospital deserts, those are like our biggest, I would say, challenges. Aside from having cultural humility and all those kind of things, those are kind of baked into the cake, I would say, here um, in Georgia, but around the country as an issue. But in terms of how we serve, and listening to moms when I first started in birth work was a study done that basically said everything we needed across the country. But now it just seems to continue to decline. So I think the policies that we need to have around access, support, and assistance, and training for providers across the board, but particularly in training, um, is important for how policy is informed if we know about what's going to be happening. So I'm not sure how long we're supposed to take, because I don't want to take up, I'm sure we'll hit other things.
Yeah. Nicole, do you want to weigh in on that?
Mhm.
Yeah, if you're comparing the US
Mhm.
to other developed countries, we're doing very, very poorly.
Mhm.
I represented the American College of OBGYNs into the society for the Japanese OBGYNs about a year
Mhm.
and a half ago. And in that, I got to meet with other board members from other countries and really look at the differences between our healthcare system and other
Mhm.
developed and some non-developed
Mhm.
nations. And when we compare our system to the Japanese, it's like night and day. First of all, the cost of healthcare is like night
Mhm.
and day. Like people that have issues with endometriosis and infertility, like that's something that's covered by
Mhm.
their insurance and the things that aren't, it's literally like $1,200 compared to $25,000 here. So there's just a disparity in cost. Of course, we
Mhm.
have our cultural norms, they have their cultural norms. Their C-section rate is way higher, but the maternal mortality rate is way lower. Their neonatal survivability is way higher, even if you compare like 22 weeks and up versus our 22 and 5 and up. It's
Mhm.
just, when you think about, 50% survival rate at 22 weeks compared to our survival rate, it's just, unbelievable. But they
Mhm.
also don't have the barriers that we have. They don't have a lot of,
Absolutely.
barriers to access to healthcare. They
100%.
also don't have distrust of the healthcare system. They
Mhm.
also don't have some of the systemic racism and barriers that we have here because you're talking about all pretty much the same culture,
Mhm.
and they have the same cultural norms, whereas the US is just like a gumbo, a melting pot of different cultures. And obviously historically,
Mhm.
the US has gone through a lot with systemic racism, and that leads to distrust of the healthcare system. So there are things that we as a developed nation have to deal with and have to, one, come to the realization that we have to face what the real issues are. And right now, there's a lot of people in healthcare, and not even healthcare, just in general, that don't want to really talk about the issues and address the real issues at hand.
Tatiana, oh, you're muted. There you go.
Well, for me, I agree with everything that was stated, but also I think I see that other countries tend to have a little bit more care for the mothers than the rush that we have here in America, right? We whole mention the rates as far as for C-sections, which of
Mhm.
course that tends to be pushed very hard, especially on women of color. C-sections are really pushed. And so I think it's just a difference of care for the mother as she is going through this process in other countries compared to here. So that would be probably what I would just add to everything that was already stated.
And I can definitely ditto that. I will say, like postpartum care in most developed nations, I mean, they stay in the hospital for a week. I mean, it's like,
Mm-hmm.
and here it's like 2 days for a vaginal delivery, 3 days for a C-section, and you're out of there. And a
Mm-hmm.
lot of, maternal mortality is in the
Mhm.
postpartum period. And in the
Mhm.
postpartum period, those visits aren't covered. That's like
Mhm.
included in the global fee. Now it'll be interesting to see what changes come down the pipe when there's some unbundling, which you know
Right.
which should happen. But I mean, it'll see how that changes. But it's interesting. Like the postpartum care is a big part of
Right.
the recovery in other developed nations.
And when there's the doula engagement, when doulas and midwives are also involved, whether it's well care or actual delivery, I mean, and that could be
Mm-hmm.
home or hospital birth, a different model of care that is inclusive of the postpartum. It makes a difference to how people show up to their own births.
Mm-hmm. Yes.
A lot more voice and choice, as I say, I've said to my mentees that I've trained, and it's definitely really important that the, informed consent and listening. That's why like the most of all, it's like listening so that you can hear what those issues are, even if there are, issues that came up
Mm-hmm.
that have, affected their health and wellness ahead of time. A big part of it is just listening to the human being. And I think when we had the grand midwives and all that, that was more in the community, right? And then serving people in their community. So I think that's what a lot of community-based doulas serve that aspect for. I mean, and that's in and out of the hospital. And I just wanted to make that clear, right? Doulas are not just doulas mostly go where their clients go.
Mhm.
Right. So it's not, that's a
Yes.
misnomer that they're only, and they're not midwives,
Yeah.
right? The clinical people are midwives and OBGs and such. Doulas are that whole health of the person, mind, body,
Mm-hmm.
spirit. Just to make sure we say that that is
Yes.
important. So policy around how we serve is important inside of that, and work collaboratively in that process. So to you all's point about creating community around the birthing families, I think that's the difference between, again, that global, respect for that care. Not that there aren't any drawbacks and critiques of that, but
Mm-hmm.
just you are like, as Tatiana, like, it's a difference in how one shows up for a family
Mm-hmm.
from here in the US. We live in silos here, right?
Mm-hmm.
Yeah, we
So,
do.
Yeah.
Hmm.
Aren, I know that you're coming at this from a different perspective than our other panelists, but when you were doing research and following it's five ladies, right?
Mhm.
That you were following, did you find differences in how things happen here versus how they happen in other developed countries?
So I think I want to affirm everything that was just shared and just to underscore that in general, the United States spends more for worse care.
Hmm.
And the way in which this shows up so dramatically is in this question that we're talking about tonight, Black maternal mortality.
Mhm.
I think that Black maternal
Mhm.
mortality is uh, the canary in the coal mine for so much that is wrong with American healthcare. It is a matter of both interpersonal racism that's measured, both shared by people's lived experiences and shows up in the research. And also the structural ways that healthcare is paid for and is delivered in this country.
Hmm.
And the reasons why we have that also being linked to American racism. I think
Hmm.
so, of course, we could talk all day about how we got here, but I think that one of the ways we got here, and I'm seeing some folks mention this in the chat as
Hmm.
well. I
Hmm.
retell the story in my book about how um, Black midwifery was eradicated and pushed out from the South
Hmm.
for financial
Because of
reasons
race.
and by white men who were looking to professionalize and take over the business of birth and delivery, although they may not always make hospitals very much money, they're still the most common reason that women are hospitalized and people at large are hospitalized. I was
Hmm.
interviewing an expert today for another story about how hospitals perceive birth as the way that, the woman is the family decision maker, as the way to create a relationship between a family and their business. It's not so much seen as this is a meaningful rite of passage. This is something, a moment of deep vulnerability for the person. So I think other countries, the threshold care tends to be a midwife. It tends
Hmm.
to be, birth is treated as a healthy event unless proven
Hmm.
otherwise. It's not
Mhm.
immediately extremely medicalized unless you do need a higher level of specialization or care. And so that's another way in which, America is spending more for worse care because not everybody needs that kind of care. And that also means that the doctors that we have that desperately want to serve people are stretched so thin, are having to do so much with so little, and the same with the nurses on the floor.
Mhm.
And so, I can certainly share some of the statistics that jumped out at me, but I think the story that we're talking about is uh, one in which we have less for everyone, in part because of the
Hmm.
racist motivations of how healthcare is given out in this country. And
Hmm.
pregnancy and birth in particular, because it is both the way that people get health, the place in which people access medical care in such a common way, and Black women in particular bearing the brunt of this, I think is where it all comes to a head. And so I think, my colleagues in media published a piece there were several pieces, and the Atlantic was the sort of most visible one a couple of years ago, saying that the maternal health crisis had been overstated. And their argument for this was that there were different kinds of measurement that were happening. And when I was reporting, and that this had changed over time. When I was reporting this book, I asked several experts to help me understand whether we would still rank at the bottom, whether the United States would still rank at the bottom of wealthy countries, let's say, rather than developed, since we are an unevenly developed country. And we would still be in the bottom of all of the wealthy countries, even by the most
Hmm.
conservative measurement of pregnancy related morbidity and mortality, and that's across race.
Mhm. That's not surprising to me at all, actually. So, Nicole, from your experience in clinical practice, what are the most common ways that Black women's pain, symptoms, or concerns are dismissed or minimized in medical settings, and how does that directly contribute to maternal mortality outcomes?
I think when you talk about specifically Black women, and obviously I'm not saying a blanket statement for all Black women, but just what I've seen is Black women will come in and they'll tell you what's wrong with them. And usually they're not as dramatic, right? So they'll say, I'm in pain or I'm having contractions or I'm bleeding, and they may not look as if they're in pain, right? And
Mm-hmm.
because of that, sometimes they can be dismissed because of that. It's like the provider doesn't believe them, right? So that then I'll see them, and mind you, I'm a high risk specialist. So everyone I see has a high risk condition or is thought to have
Mhm.
something high risk going on, whether that's something that, their baby is suspected to have abnormality, or their mom has fibroids, or she may have a history of a heart
Mm-hmm.
disease, or something going on when I see them. So for me, I'm always at high alert. I dig for issues. I want to make sure the patient is safe, and because my job is to make sure patients get safely through the pregnancy, they have a high risk of not getting
Mm-hmm.
through the pregnancy.
Mm-hmm.
So I'll have patients that'll say, yeah, I mean, I'm having this pain here. And I'm like, well, how long has that been going on? And they're like, for about 2 weeks. I'm like, did you tell your OBGYN? Well, yeah, I did, but they told me it was normal. Or I'll be
Right.
like, did you tell your provider? Yeah, the midwife told me this is what happened and this is why. I'm like, let's do a little bit digging with that. Like, because for me, it's not normal until I rule out that it's abnormal. That is not abnormal. So I think because, people may not look as if they're in pain because people tell me all the time, well,
Mm-hmm.
she didn't look like she was in real pain. I'm like, yeah, but she's contracting. Like if you put her on the monitor, she's
Mm-hmm.
banging out contractions, but just because she's not like acting hysterical or rolling and writhing around in the bed doesn't mean that she's not in pain, and we should take their pain seriously. When I see patients that have sickle cell anemia and they're having sickle cell
Mm-hmm.
crises, commonly pain will be dismissed like, oh, she already had 2 doses of Dilaudid. I'm like, well, give her a third. Like she's really in pain. Like she
Really?
has a reason to have pain, but it's almost like when I'm consulted, sometimes I'm having to convince people like she needs to be
Mhm.
treated. People that have fibroids that may have fibroid degeneration, they'll be like, oh, well, this is just, she just has a little bit of fibroids. I'm like, I have had fibroids myself. Like when they degenerate, it is like the worst pain that you'll have in your entire life. And we know that it's going to last a couple weeks. And we know that this pain is real. Like there's been study after study that shows that people really do have pain, and
Mm-hmm.
that pain has been dismissed or undertreated. People have been called drug seeking, especially people that have
Mhm.
chronic pain issues. I'm like, if somebody has a reason to have pain, their pain should be treated. They should not be assumed to be drug seeking. So I see that pretty often. People
Yeah.
that have issues and have a reason to have chronic pain, and it's dismissed, and it's not until I've seen them that their complaint is being taken seriously, and we're doing some further investigation. Unfortunately.
Dr. Plenty, do you mind if I ask you a question about that? I'm curious, and Julie, I hope that's okay. I'm just curious about whether when your patients are not expressing their pain in a really vocal way, whether you think that there's a fear that if they do so, that they might be dismissed as a sort of like stereotypical angry Black woman, or they just feel like what do you think is behind them
I
not
don't.
being loud about their pain?
I think that some of it is just being a Black woman. I
Yeah.
don't think Black
Mm-hmm.
women, we're not huge complainers. We are, and I'm not speaking for all Black women, but the
Mhm.
majority of us have endured so much. Um,
Right.
we just sort of kind of deal with it,
Mhm.
right? Like we're
Mm-hmm.
exhausted, but we're still going to keep going. We're in
Right.
pain, but we still got to go cook for a meal for our family. We still got to go work because we got to make this
Right.
money to pay these bills.
That
So we're
part.
used to just sort of kind of dealing with it. And it's not that we're not vocal. I think that because we're just like, well, I've been dealing
It's
with it, so I'm going
different.
to deal with it. Um, that it's not surprising to us that people aren't just pausing
Yes.
what they're doing to address it, but we really should be pausing what we're doing to address it and have people
Mhm.
prioritize themselves. So that's why I'm like, I'm glad that I'm in on a panel with doulas. I think every
Mm-hmm.
high risk patient should have a doula.
Mm-hmm.
Every high
Definitely.
risk patient should have a doula.
Definitely.
Somebody that's like, no,
Yes.
no, no, we need to talk about this. Like, make sure you get
Mm-hmm.
your answer
Yeah.
before you leave the room and write it down so that you can understand.
Mhm.
So I don't think it's
Yeah.
that people are like intentionally ignoring, and I don't think that Black
Mm-mm.
women are intentionally not trying to speak up. I think that we're just
Yeah.
so used to dealing with it that
That.
we're pregnant. It's just sort of like, okay, well, just gonna suck it up and I'm just
Yeah.
gonna.
Right. And
Also,
that's the
also
piece right there. The
yeah,
one thing that I was going to say too
yeah.
is that I want to really make it clear, and I think that all of you would agree with me
Mm,
that this absolutely crosses all socioeconomic
it does.
statuses. It
Yes.
does not matter if you have the top Cadillac insurance or you have no insurance at all.
Yep.
We
Mm,
all are just as likely to die
Yep.
at the
hmm.
same rate, and,
Yeah.
and and that part does not matter. So
Yeah.
this is really,
Yeah.
because I have experienced this myself. This is
Yeah.
very, very serious.
Yeah.
To me.
It's the great equalizer. I call pregnancy from beginning to postpartum. It is the great equalizer of how we endure. And I think the other piece of that to your question, Aaron, and adding on to what Nicole said, it's just a matter also of language and how we communicate our pain. Or, and I've also been on the National Task Force, Racial Disparities Task Force for the Preeclampsia Foundation. And one of the things was just how we say, oh, I just have a little sugar,
Yeah.
right?
I just have a little headache. It's
A
probably
little headache,
I
it's
didn't
probably, I
eat
just
much,
need
so
to,
I yeah.
right. It's literally, so like in terms of the patient side, is how learn, that's why you have to learn and
Mm-hmm.
listen to how the person that's in front of you communicates their actual sense of pain and or what's going on with their health, right? And how they document that and hold on to
Right.
that information. So it is important, like those 15 minutes, if you're gonna only spend 15, you better be listening the whole time, and I think that's where the challenge comes
Yeah.
in as well, to cut across. All right, go ahead, Julie. I'm
Tatiana,
sorry.
as a doula and a therapist, what practical tools do you teach Black mothers to help them advocate for themselves in a medical setting? And can you share a moment in your work that captures what this crisis really looks like on the ground?
Yeah, sure. And I can actually start off by saying, and I was going to mention this, that as far as for Black women or women of color, we come into everything pretty much with our bodies already worn, full of stress and discrimination, which is why we are not animated oftentimes when we have
Mm-hmm.
a pain, right? Especially if you're a new mom, you don't know what pain you're supposed to have and not supposed to have. And what
Mm-hmm.
pain somebody says that most pregnant women have doesn't mean you're going to have it or it's going to feel the same way. So, as a doula as well as a therapist, because they do intertwine sometimes, from a doula standpoint, I make sure that my moms know how to advocate for themselves.
Mm-hmm.
Use your brain. Is this the
Yeah.
best option for me? And brain is an acronym. So, like, is
Mm-hmm.
this the best option for me? What are some other options? What else can we look at? What are some of the things that can happen to me? Generally, in hospitals, everything tends to be rushed, right? I started off by saying we're like a microwave society. So, everything
Mm-hmm.
tends to be rushed. So, going over everything just for you to sign, everything is so quick. And I let them know this is your time, so you can slow it all down. If we're not in an
Mm-hmm.
emergency, like if
Mm-hmm.
we're not coming in here bleeding, having to be wheeled someplace, then we can slow this down and you can ask your questions. And I don't just focus on the mom, I focus on the family as a
Both.
whole. So
Mm-hmm.
anybody that you say you want in that room or want to have that information, your partners, there, everybody, I speak to everybody and I make sure they understand. So if your partner or your spouse is in there and you don't have the voice, that's their time to step up for you and ask those questions. And so I
Mm-hmm.
tend to help my clients, or excuse me, my moms with that, as well as I let them know I cannot ask the questions for you. I need you, like, you have to start. But
Mm-hmm.
once it's started, it's my job to say, okay, did you understand what they just said? Do you have
Mm-hmm.
anything else that you want to ask them? Anything that you feel like you missed? Because 9 times out of 10, we're
Yeah.
in this moment of a lot of things are happening that I mean, anyone, it's just happening so fast. We don't know. And I think the generation now is a little bit more well versed than other generations were. So
Mm-hmm.
they're quick to say no Pitocin, know this, know that, and they're serious about it. And then with my clients, I tend to deal with clients from the aspect of infertility and going through IVF and being
Mhm.
told sometimes that you'll never have a kid unless you pay all this money for it. And just
Mhm.
having to deal with some of the things that are said, one as women to us, but also as Black women. I know Julie mentioned, like where you are in the world as far as your social economic status. It really does not matter because sometimes we get talked to as if we know nothing, as if
Mhm.
we don't know our bodies, as if we like they are the expert and that's it. Whereas that is true. You got the education and those things in that area, but I do know my body. I had my daughter at 28 weeks. Of course, she was a preemie. I had to be Trendendale. I was inpatient, all the things, and I am so grateful for people like you, Nicole, because that's how things got caught. But I'm also grateful for my OB who believes, unfortunately, geriatric pregnancy, right? Being 38, 39. That was just what they did. And I can honestly say that even though I was in that situation, I had good people that listened to me because I was in labor, didn't know it. My water broke, and I was just like, yeah, this is happening, which still goes to not being animated, right? I was
Yeah.
like, I feel like I keep peeing. What's going on? And they were so grateful. And I ended up having a good experience within a lot of trauma. And not everyone gets that. But I want to make sure that my moms get those experiences, that they are heard. So if you say, I do not want to lay on my back, it hurts.
Mhm.
Well, then we're going to work this out. You're going to explain to her why she has to lay on her back when technically she does
Mhm.
not. If she does not have anything that is stopping her, meaning no epidurals or anything like that, then hey, you can do some movements. And we have now the wireless monitors where they can still monitor
Mhm.
you
Yeah.
and everything. And so sometimes it's just the way people want it to be. So it's like you need to just lay on your back. Well, you need to give
Mhm.
them more information as to
Yeah.
why. And I think that might be why doulas are becoming more respected. But I also feel like that's why sometimes, depending on the hospital and the nurses, you bump heads because they don't like having to go into detail in things. And so with doulas, I make sure to help my moms know
Mhm.
people can go into detail and you have a right to have a understanding of things because sometimes once you have that understanding, you're more apt to say, oh, okay, that makes sense. I can do that and not get a
Mhm.
pushback so much.
And I want to just add in terms of the mental health part, like people um kind of skip over, I don't know, I have a little bit of the opposite like window. I think not a little bit, not Tatiana, the just
Mm-hmm.
women will come in and they have, anxiety. Some of them they over research, so they have anxiety. And a lot of what we have to do is, I used to call it the clicker, the clicker, but now it's
Mm-hmm.
other stuff. But the anxiety that they carry, anxiousness about what the anticipation, and
Mm-hmm.
sometimes I mean, and then also people also don't know their bodies. It don't matter what age they are because they have given the
Right.
authoritative knowledge over to the person who is giving their care. And so the anxiousness, along with the stress, right, becomes that loading, that
Mm-hmm.
allostatic load. And so we want to make sure in that. So I would usually introduce, I'll just say you, a perinatal mental health person early. In the,
Yeah.
that's as soon as I see it. And then get them in that relationship. You know what I'm saying? So that is an important part of them
Mm-hmm.
being able to, one, I used to prepare them like you with questions every time they went in, so that and their
Yeah.
partner along with them, so that partner can advocate and have the voice as soon as, like you said, as soon as your like skills or you're in your body, your partner can say, and I used to call it the trifecta of support, right? The
Mm-hmm.
partner, the birthing person, and whoever the provider is at the moment, that's the key. It could be the doula, it could be the clinician, but
Yeah.
mostly it's that collaborative team. But I think just kind of paying attention to that mental health
Mm-hmm.
component is so key. about what's the status in terms of home, in terms of from the doula perspective, like you're saying, but also what kind of clinical things might be showing up around that in the prenatal period that can be helpful for planning for and getting their voices ready to prepare for a postpartum period and beyond, and what could be taken care of.
Yeah.
But I just kind of want to put that in there because that perinatal mental health piece is always um, anxious for me as a provider, as I've supported people, you know. It's like,
Well,
ooh.
we've talked a little bit about how we present when we come in, women of color, Black women in particular, when we present to medical establishment, and this really transcends even giving birth, but that's our topic for tonight. But when we come in, so we talked about that as being one of the root causes because we don't present, you know, animated, I
Yeah.
guess.
Mhm.
Um, and so we've talked about that. We've talked about a little bit about, the systemic racism and in the way that that kind of plays a little bit into this. But are there other causes too that you would add to this list that are driving this mortality and morbidity problem?
Um,
Um,
is
well,
is it okay if I want to just share some of the research that jumped out at me when I was researching the context, because one of the five women that I write about in my book, Unbearable, Christine Fields, a mother of three from Brooklyn, New York. I write about her throughout her pregnancy. Her third pregnancy, she was 30 years old. She had two healthy births. She had a completely uneventful third pregnancy. She went back to the hospital in Brooklyn where she was born. And I want to add, because we've been talking a lot, I think we started out talking about the South, and we have so many incredible advocates here in the South. I think many people who live in blue states tend to assume that this is a problem that is just present in
mm,
red states, and it's
Mm.
absolutely not the case. So, one
mm-mm,
of the reasons that I wanted to write about women both in Alabama and New York City, where I live, is because during COVID, I realized I read a statistic that said that the racial disparity in maternal mortality nationwide is an unforgivable 2 to 3 times. In that, Black women are 2 to 3 times likelier, depending on the year, to die from pregnancy-related causes than white women. But in New York City, during the time that I was writing about, Black women were 8, 9, 12
mm-hmm,
times likelier to die than white
Mhm.
women. And we cannot cry poverty here as a city. We cannot say that we don't have liberal policies or liberal decision makers. And so, although it's living in a maternity desert or not having
mm-hmm,
expanded Medicaid, these are all really important factors in Black maternal
mm-hmm,
mortality. They don't explain why in the wealthiest city in America, these
mm-hmm,
disparities are so dramatic. And so, through the story of Christine and a white woman who went to the same doctor at the same hospital, I attempt to understand both the systemic and the interpersonal factors. And so I would flag, the answer is always both. So, just want to flag some of the research that really jumped out at me. For example, the reason I asked that question about how patients are presenting is because
mm-hmm,
there's research showing that when Black women advocate for themselves, they're more likely to be retaliated against by providers than
mm-hmm.
when white women do so. If they decline procedures, if they request procedures, you talked about being
Difficult.
being
They're just
right,
labeled
being assumed
difficult.
as being difficult. And so I
Difficult.
wondered whether in your
Yeah.
observation and your experience there had also been
Mm-hmm,
a kind of preemptive, because in the woman that I wrote about, by the time I was writing about her, she had lost her life, but her partner, Jose, and through her
mm-hmm,
family and her friends, I was able to, and her, what the documents that she left behind, I was able to tell some of her story. And Jose, her partner, said to me that when they were asking for help at the hospital, that they were really aware of this, that they didn't want to be difficult. He didn't want to be thrown out of the hospital. Um, that they felt that they were ignored when they asked for things and when they declined things, both because she was declining interventions, but then when she wanted to be seen, they were ignoring her. as a form of
Mhm.
retaliation. Okay, you didn't want this? Fine, I'm going to leave you in a room for hours after a C-section to bleed out.
Mm-hmm.
Is what happened to her. Um,
Mm-hmm.
there, speaking of blue states and holding blue states accountable, there's dramatic research out of New Jersey about cesareans that showed in a huge population how the availability of an operating room, so the just people wanting to fill spots in an operating room, only when it came to Black women was it much more dramatically likely that a low risk Black woman would be given a cesarean section, sometimes by the same doctor. A white woman would be allowed to proceed to a vaginal birth. A Black woman would be much likelier to be recommended for a C-section without any kind of risk factor, simply because it was more convenient and more profitable for the hospital. And they had this
Mhm.
enormous data pool in which they were able to show those specific decisions in which they controlled for things like weathering and social determinants of health,
Mm-hmm.
and other risk factors. Um, the other research that, to answer your question, Julie, about what else it is that's happening is that there's also, because of the systemic disinvestment in hospitals that disproportionately serve Black women and Black populations, um, there's been research that has found that the choice of hospital, that if you go to a hospital that disproportionately serves Black patients, that Black women are more likely to have adverse outcomes or to lose their lives. And of course, that's not just a judgment on the hardworking people at that hospital, but the resources that they've been given to and the access to specialized care and the access to nurses on the
Mm-hmm.
floor and to time. In the case of the hospital I wrote about in Brooklyn, there was a hiring freeze. There were Medicaid cuts at the state level. There were doctors who were known to be
Mm-hmm.
bad actors, who were known to be harming patients, but they were afraid of firing them because they were afraid they wouldn't get another one. And they
Yeah.
were public hospitals that were being paid less by private hospitals. So people would cycle through there, and if they could get a job somewhere else, they would. I think that all contributes to the inexcusable figures that we're talking about here tonight.
But I think also too what you said about, I mean, it's it's all about capitalism. I kind of like undercuts all of it, right? I mean, from being able to afford insurance to I go without insurance until I absolutely need insurance to the Medicaid issue, right? But I think part of that and some of the angst, so I
Right.
keep going with the anxiousness narrative, right? Because when you're anxious about when you have to go back to work. That was me. Why do I have to go back to work right now? Don't call me, right? Don't call me. I'm supposed to have this time off, right? But parental leave is huge. And I know somebody in the chat, I think one of my people did, mentioned
Yeah.
that parental leave being a big issue. And we just had some policy start to pass. So, but I just think that we don't really curate those spaces well, with culturally competent, human connected people. I'm just going to say that.
Mhm.
And really, and I say competent, but humility. Understand that you come with some biases and don't be like, oh, I don't know what kind of biases I have. Everybody has you from
Right. Yeah.
body odor to something real significant like the socially constructed race issue, right? But it's just really pay attention to that and class. I mean, and that can be that doesn't have to be race based.
Mhm.
Mhm.
Okay,
Yeah.
class issues are an issue. Social determinants, everybody has a social determinant, but just how high are you on that, right?
Mhm.
Everybody
Yeah.
does. But, and it's not just like you said, low income women, but specifically when it
Mhm.
hits in rural, low income, keep putting all the qualifiers of what makes a perfect storm of what a maternal mortality or morbidity issue here we are, we land in these numbers being horrific with those stories that you just shared, Aaron. I think it is, and it is across the country. I mean, most of the doula um, textable text expertise panels that I've been on, it is a conversation that we're having from West Coast to East Coast, North, South. So it is definitely, the birthing body is attacked, and then specifically Black women. So how do we start to curate a different way of being inside of that is important. But insurance, insurance, insurance. I'm like, I'll be saving my ducats because it ain't going to be about insurance. That's and however we need to meet that with
Hmm.
community-based programs is important. And there's a lot more of those going on. And Nicole, you're in the WellStar system that is trying to do some good work with that. So I, in Metro Atlanta. So I do and support that. And let's help the family to Tatiana's point with being able to do that. And that's how we answer. So
Um, so Nicole, where are we seeing promising solutions, whether it's in hospitals, communities, or state policies that are measurably reducing disparities? Or do we see it anywhere?
Hmm. When you said that we're seeing promising, so we're seeing solutions in little pockets, right?
Mhm.
And the
mhm,
solutions aren't big enough for you to see a needle being moved. I mean, yes, there are systems that are, big like Wellstar that do have free doula programs. So you can have a doula during the pregnancy and then, up to, 12 weeks after you deliver for free. There are, different programs that fund undocumented and underinsured patients so they can get access to, high risk specialists when they need one. But now we're starting to see it's almost like you take a couple steps forward, right? Because we're trying to do mobile units because in Georgia,
mhm,
there are 80 plus counties that have
mhm.
no OBGYN. And now I'm not talking about a high
Right.
risk specialist, but just like an OBGYN. And there are counties that have no
Hmm.
midwives either. So when you're talking about, access to care, we have to try to be more creative. So we are
Mhm.
trying to be creative and creating more mobile practices, making more virtual clinics, making more telehealth monitoring for fetal monitoring and blood pressures. That is a good thing. Those are forward steps so that we can catch undiagnosed preeclampsia and we can catch growth restriction and monitor patients that can't get to and from those clinic visits. So those are steps that are positive. And then all of a sudden you have decrease in funding of some of these programs.
Right.
Yep.
Underfunding of, programs like Baby Born Healthy that treat, undocumented patients. Now, you have millions of people that won't have Medicaid funding, and now you're like, people's premiums are going up as of this year. People are like, man, I was paying, 100 something dollars a month. Now I'm paying like $300 a month for
Mhm.
my Medicaid.
It is.
And so now we're
Mhm.
going to have even more barriers. So we have more underinsured patients that are picking plans that don't insure as
Yeah.
much just because they can't afford as much. And
Can't
so
afford it. Yeah.
I'm holding my breath now because I know that that is going to
Mhm.
create more of an access to care issue. And if you initiate your care late, then we know that you come and you're like, oh, your baby already has growth restriction. I can't take any more
Yeah.
steps to reduce that risk. You already have preeclampsia. You already have gestational diabetes that's uncontrolled, and you have polyhydramnios. So now we're dealing with later stages of adverse pregnancy outcomes. And so, yeah, we did
Mhm.
do some things that are promising, and we're still moving toward those promising
Mhm.
things. But if
Right.
people don't have access to those things,
Right.
now we're putting more and more barriers between it. It's like, oh my goodness, what are we going to do now? And now we have to face
Hmm.
this whole issue with patients are literally not coming to clinic visits as frequently, or they're trying to reschedule their visits because they're worried about ICE, they're worried about their family members. I have
Yes. Yes. I
my
was
clinic
going
that
to
are
say.
crying because their husbands are detained and now they have no resources to pay for, their bills. So there's just more and more barriers that are
The
coming.
load.
So we're taking steps to try to help with those access issues, to try to make sure we're
Mhm.
catching things that do increase maternal morbidity and mortality. But then all of a sudden, that line gets drawn again where people don't have access to care, people are afraid, people don't have
Yeah.
resources plus inflation. So,
Mhm.
so there's a lot going
Capital.
on in the world today.
Yes.
A lot of things that we're going to have to push harder. So I can't really
Mhm.
confidently say that we really let turn, turn any needle back. I think we have a lot of work to do in this area. And I think when it comes to maternal mortality and morbidity, we have to, yes, systemic racism is an issue. We have to deal with that. Yes,
Mhm.
there are different,
It's
comorbidities
everything.
that people have to deal with, but we have to deal with healthcare in this country in general.
Period.
If
Mhm.
people are healthy coming into the pregnancy, they're more likely not to need me. They're more likely to
Yeah.
be able to have their home birth or their low risk provider and not need an OBGYN or a maternal fetal medicine specialist. But if people don't have access to care before the
Period.
pregnancy, then it's like we're almost at a disadvantage. And when you
We
look at
are.
those
Mhm.
developed nations, they
Hmm.
have that access. There's a big push
Yeah.
about preconception care and making sure that that care is optimized and planning. When you look at nations like Japan,
Hmm.
they don't deliver. You have your low risk patients that deliver at a birthing home and they have midwives, and then you have your high risk patients that have OBGYNs and they have MFM specialists. And they are
Mhm.
It's
structured.
very
And
different.
there are times that you check in and say, who moved from low risk to high risk? We don't have that very well in place to recognize
Yeah, we
who
don't.
is low risk and who is high risk. And there's also not much of a collaboration here. I feel like
Yes, collaborative
providers
care.
almost
Hmm.
Yeah.
pit against each other. Like I have in my office, I have I have a midwife that works for me. I have a nurse practitioner. I have other maternal fetal medicine doctors, and then we have our referring OBGYNs and our referring midwives. And in the Wellstar system, it pushes you to work collaboratively.
Mhm.
Hmm.
But that's
Yeah,
not how it always
it's not
is. I
everywhere.
have, midwives that contact me directly, even though they have a designated OBGYN because they're like, their schedule doesn't allow me to talk to them. And
Wow.
I'm like, we're all taking care of the same patient. So of course I'm going to
Yeah.
communicate
Right.
with whomever is referring to me, but it's almost like, well, I'm the midwife. I can't ask my OB. I have to prove that I can function independently. And
Hmm.
I'm the OBGYN, and this
Oh.
patient doesn't want to see the MFM. So I'm going to handle this by myself. Why are you trying to handle everything by yourself? Should be a collaborative conversation, and that we're talking about where the
Collaborative.
patient
Yeah.
needs to be and who needs to be the person taking care
Hmm.
of them. And I just feel like there's not much collaboration, and I don't really know why that is.
Mm.
Coming from Texas to here, Georgia is way different than Texas.
Yeah. Hmm.
Indiana was different than
Hmm.
Texas and different than Georgia, and everything functions so
So
differently. And I
differently.
look
Yeah.
here and I'm like, I don't understand. Like, how do we have patients that have all of these diagnoses and they don't have a collaborative team? It is
Hmm.
mind-blowing to me.
Mhm.
Hmm. And
And so,
that's like we've been trying to your point, we've been trying to, when I say I've been at these tables for since 2013, where we've been trying to, along with the bundles that we
yeah,
have, we've been trying to think collaboratively, be collaborative. But again, to your point, we break apart like who it's a power hierarchy, like
right, and
who
I don't
Yeah.
serves
understand. I'm like,
who. And it's like, why? We're all vested in these families.
yeah,
Let's start
Yeah.
to create this collaborative care teams. This is coming up more and more in conversation, but let's just actually implement them.
right,
Or it's
Yeah.
up to one or two of the people on the team to start. I mean, that's what I started to do as a doula. I'm going in, I need to meet this person, to where when you
Correct.
do a better birth, and then it's like, okay. I mean, I've had many times when it's like, okay, me and the partner got the mom to this point. That's what she wanted, particularly for a rainbow mom. And it's like, oh, the doctor and I had talked. We were like, okay, her OBG, her specialist, we had talked, and at what point she's like, I'm going to tap out. But then everybody was like, but we know you want to have a vaginal birth. And everyone talking together about what that means, to
Right.
where the mom was like, uh, okay, call the doctor. We were like, okay. And he was like, but
Right.
no, we can
Right.
go longer. We know that you want this. And she's like, wait, I didn't expect you to say that. I expected them to say that. So I'm just saying, it's just an example how when you're working together, and even when we made the decision and the call to do the C-section, right?
Mhm.
He was
Hmm.
like, I
Hmm.
didn't push her, did I? I didn't do, I said,
Right.
no, you
And those
didn't.
are the doctors that you
Yes,
love. Those are
yes,
the ones that
yes.
you do want to work with. So as a doula, I make sure to at least try to go to one or two of the
Mhm,
appointments to meet the doctors, to do those things so they'll
mhm,
know what face will be in the room with
mhm,
them.
yeah.
Um and and to Nicole, for one of your questions, and I'm in Texas,
Mhm,
but what I have found as a doula, um, and they're just at certain hospitals. And I know I saw somebody in the chat saying that a hospital
yeah.
somewhere banned doulas. I think there's this idea that we are trying to take over the job,
Mhm,
you know,
mhm,
and We
No.
don't catch babies. That's not what we do. I don't think any of us is interested in
Nope.
doing that. And on top of making sure I'm there for the family, I'm also saying, how do y'all need me to help? You need me to hold a
Yeah.
hand? What do you need from me? Like,
Mm,
let's all be on one accord, which is bringing this life into the world, right?
Mhm.
And so when you get those doctors, I've had nurses try to be very combative with me, and I'm like, I'm
mhm.
not a nurse, and I'm not
Yeah.
trying to be one. But it's great when you run into a nurse that is a doula too, that has done the
Mhm.
class, that now
Yes.
understands it from a different.
Mhm.
It's great when you
Mhm.
run into a physician who, like what you were just explaining, is like, we can do this. Like, you don't have
Mhm.
a reason for me to rush this. You're fine going 41 weeks. But
Yeah.
once we get to 41 weeks in here, we got to look a little different. Like,
Mhm.
those are the ones who feel like I don't want to push them. I want to make sure that they have informed consent, they have
So
informed
yeah, yeah, yeah.
information. And so I think that power struggle, like you all were saying, is also why this collaboration cannot
Mhm.
happen on
Mhm.
top of money. I mean,
Yeah, money,
money is the
money.
root of all evil. It's always going to be
Capitalism.
something that's going to be like, well, if I collaborate with them, but I think it would just be so much easier if we if
Yeah.
we all could
Yeah. It
collaborate
would.
and everybody understands, what their position is, and you trust that those people know that.
Yeah, because everybody has a role, right? Like
Yes.
bodies aren't competing, and I
Mhm.
think that that
No.
is a misconception. People's
Yeah.
bodies are not is not competing, because everybody has a different role, and if everybody understands their role, then
Mhm.
everything would go over much better. And then even the patients, they can tell when there's
Yeah. When there's
conflict. They
tension.
can
Yeah.
tell when
Yeah.
there's tension, and we don't need to bring that into the patient's atmosphere because
Mhm.
then obviously that pushes their anxiety. I think that some providers, and I can say this, like I'm a provider, I can talk about us, because that I know how we are. So some providers, especially, and they'll tell you, well, Nicole, you're MFM. You're right. I have more time to spend with patients, right?
Mhm.
I get consulted
Mhm.
and they'll be like, well, this patient, she has preeclampsia and she's refusing delivery, right? Can you go to the consultation? I'll go to the consultation. I'll explain what we're going to do. I'll explain conservative management and how long we're going to try to prolong the pregnancy. And the patients, I'm telling you, 99.9% of the time, will be like, okay, nobody explained
Mhm.
that to me. Nobody explained
Right.
why I needed to
Mhm.
be in the
Yeah.
hospital. Nobody
Right.
explained why I needed to deliver at 34 weeks. And so once you actually break it down and say, okay, these are the risks, these are the things we're going to be looking for every day. These are the questions I'm going to ask you every single day. These are the parameters of your blood pressure I'm going to be
Mhm.
looking for.
Mhm.
Your baby's small. These are the Dopplers. Let me explain what the umbilical artery Dopplers mean. And once you
Mhm.
explain that, one, it's good because then if a patient sees it, they know, they see it's abnormal because they've been educated in what to say.
Right.
And so then there's not this pushback. We're all on the same page. We all get a good understanding.
Mhm.
The problem with a lot of providers, and it's not really their fault, they're on time, right? The hospitals have these quotas. Everybody has
Yeah.
different goals they
Yes.
have to reach. They have a certain amount of volume they have to get to
Yes.
make and keep their salaries. They're taking care of their families. So it's a time factor for them, right? And for
Mhm.
them, for OBGYN, they're not billing off of time. They're billing off of the number of deliveries, the number
Mhm.
of
Yeah.
patients that they see. And
Mhm.
if you have a patient that already is anxious, they already know I'm a
Right.
black, because people come in,
Right.
please don't let me
They don't
die.
want to die. Mhm.
I saw on TikTok that XYZ happened, and I don't really know why this doctor died. Like people are on edge.
Mhm.
And so a
Mhm.
lot of what I do in my first consultation is to go through their history, go through what's really your concern? What are you really
Mhm.
um, anxious about? And just reassuring them and telling them the plan and how they're going to be monitored and how they're going to be watched. That takes time. And so if you have a doula in the room and a
Mhm.
patient that's very anxious and an OBGYN that's like, I only have 15 minutes, right, to talk to this
Mhm.
person, then it's like, pushback. So they figure if I can't convince this person to get on board with this plan in a couple minutes, then they're being resistant to my plan. They're not respecting what my authority, they
Right.
don't trust me, right? And so that's the push. And so it's a combination of these unrealistic metrics that the systems make and the insurance companies that are only going to pay for so much, for so much time, that is causing more constraints. So that's why there's this, well, they have a doula. They're going to be difficult. I mean, that's where some of that comes into
Mm-hmm.
play.
Well,
Mm-hmm.
so we are already at time and we didn't get a chance to even have Julie come on and ask some of the other questions. But the one thing that I did want to make sure that I got asked of all of you, what is one thing, and please keep timing in perspective. What's one meaningful thing that everybody on this call could do to help address this issue tomorrow? Obviously, we can't make folks work nice or play nice in the sandbox. We can't do that. But is there is there a phone call that can be made? Is there something that can be done? Is there something that the folks on this call could do to even bring more awareness to this issue?
Well, I think
So
that,
many
you know,
things.
one, sharing this information that you learn, telling
Mm-hmm.
somebody to go back and watch this, and join the conversation. Of course, there are different legislations coming down the pike.
That's
Always
what I was
reach
gonna
out
say.
to your
You're a
congressperson.
legislator.
Yeah,
Mm-hmm.
and say, hey, listen, this particular bill affects all of us. You really need to, vote for this. I mean, people listen to their constituents because they want to get voted back in office.
Yeah, they
And
do.
so many people don't reach out to their legislators just to let them know, like, hey, I know about this bill that affects maternal health. I know about this funding that got cut. Send an email. That would be probably the most helpful thing. It doesn't cause
Mm-hmm.
immediate change, but it does allow the
Yeah.
conversation to continue to happen.
Show up and show up. So I just came, we had a Capitol day at the Capitol. Whenever there's a day at the Capitol, show up and they will listen to you. You can talk to them in line as well as, follow up that piece of it. But also when you see voting, when you see Medicaid coverage or something having to do with maternity, vote for that support.
Mhm.
I mean, it's nothing going on other than saying we
Mhm.
need this support for anything related to maternal health. And show up on, like I said, show up for these conversations and tell a friend and then support that friend who might be a
Yeah.
birthing person. I mean, show up and then show out by sharing more of what the stats are and introduce them to a doula to help them be engaged. So,
Tatiana?
And I would just say, support those organizations that are trying to help with funding, right? We all talked about funding being an issue. And yes, we can do the legislation because we want to vote. You need to vote, but
mhm,
also we have to help ourselves. And when I say we, I don't just mean Black people, I mean
we do.
we as Americans, we have to learn to help ourselves as well. So look for those organizations that are helping Black moms or moms of color or
Mm,
undocumented, under insurance. Look for those
mhm.
organizations. And if you can, go ahead and donate. Give your time.
Yes,
Ask them, how can you help
show
spread the
up.
word in
Hmm.
that way as well? Because that is also good. And then for yourself, get well versed in this issue and start conversations. The CDC actually has a website about Black women and the mortality rate and what they're
Yeah.
trying to do. They also have a program that
Mhm,
they have. So get
mhm.
well versed in this issue and just
Yeah.
start random conversations. We start random conversations about everything else.
Mhm.
You could
Mhm.
start a conversation
Definitely.
about something that can make
One
an
of,
impact and a difference. Go on TikTok, since TikTok is
oh Lord.
where everybody goes to everything else. So start
But
your conversation there.
I'll just say one of those organizations is Postpartum Support International. Definitely with the maternal mental health, because mental health period is an issue in this country,
Mhm.
taking care of
Yes.
ourselves. But
Yes.
to your point, I just wanted to back up the therapist situation there. But with definitely mental health services that support is important.
Yes.
And but definitely Postpartum Support International is one of those um, entities where you can do that. It's just important that we do that.
Mhm.
So,
Erin, do you have anything to add really quick?
Yeah, I mean, I want to say, listening to everyone's conversations, time, there was something that a midwife who also researches birth equity said to me during the course of my research for my book that I think is so relevant to our conversation here, which is she said, time is what we give to the people and the things that we value. So the structures don't want us to give time to these issues or to individual patients who need things. Um, and that same person who's doing important work on midwifery integration in hospitals, the week that we were talking, had just found out that she was stripped of her research because it had the word equity in it. Because of, the ways that they, on a national level, this research and this work is being harmed. And so I just want to underscore, I think folks have mostly talked about local work that's happening because that's the only place where things are moving right now when the federal government is actively hostile, when they're saying they want certain people to have a lot of babies, while at the same time shutting down research and care that could actually make things safer for everybody, for the mom, for the patient, for the baby, for the families. So I just want to name that. There was a question in the chat about what role partners have, and whether Black men in particular who are advocating for folks, for the patients in their lives, might be perceived as more aggressive or hostile. Another piece of research I want to mention that I came across in my reporting is that regardless of the race of the patient, if the patient has a Black partner, they are more likely to report that they themselves experienced mistreatment giving birth. It was an incredible program that Jose, who I wrote about, Jose, the partner of Christine, who died in the course of giving birth in a preventable way, he has now become a doula through and a maternal health advocate. And so I just want to flag one thing that folks can do is they can check out this very cool program called Dads to Doulas that is about supporting men of color and helping train them to become advocates for their family members in hospitals. And it just seems like a really innovative program and came up in the questions. So I wanted to flag that.
I know we don't have a
Thank
Anthony
you.
Canal. We have a few of those here in Georgia.
Yeah, look at I do think it's very important for the men to show up. I know that what your data is showing, but when the husbands are present and the fathers are present, whether they're married or not,
Yeah.
there's just a certain level of respect that patient gets. Okay.
Yes, it is.
I highly
Yes.
believe that patients that have people there with
Advocate.
to advocate for them get a different experience. And even my patients, when they come in by themselves versus when they come in with their husbands, it is different. It's like the husband's like, wait a minute, tell her about this and this and this and this. And the patients are not forthcoming all the time. And the husbands are there, they're more likely to
They
be
will tell.
forthcoming. So
Yeah,
I'm
they
always like,
want
where's your
to.
husband? Where's your husband? Did you
Well,
bring him? Because I do think that, and I think
Yeah.
that it does lead providers, not just myself, but all providers, to want to explain things a little bit more thoroughly when there are other people in the room. So
That
I
is
Mhm.
true.
tell
well,
people to
I,
bring
I have to
I,
thank
I,
all
I
of you
would
for being
dovetail
here
and oh,
tonight.
go ahead. Sorry.
I'd have to thank all of you for being here tonight. We could go on for probably a whole nother hour or
Hour.
two, but we don't have that kind of time, unfortunately. But thank you so much for coming and for sharing and for giving folks ideas on things that they could do even tomorrow or in the future to help with this issue because it's not going away. As Nicole said, it's not going away, and we all need to be doing what we can. Julie, I'm going to kick it back over to you.
Okay, well, I think you wrapped it up really well. If you want to stay connected with Red, Wine, and Blue and you're not on the app already, go to the App Store, look for Red, Wine, and Blue. You can follow, we do obviously do a lot around reproductive freedom, so please follow that issue and us. And they're calling for a second panel, y'all, so
Yeah,
we'll
We're
see.
down.
I think
All
we
right,
need to do part two.
thank you,
We're here.
everybody.
Thank you so much.
You,
Good
everyone.
Great
night.
to be with
Bye.
you all.
Bye-bye.